We shall now go on to our next speaker, who is Dr.Aarti Nangia. We all know her, consultant ophthalmology and practicing at Max Super Specialty Hospital. A strong woman ophthalmologist to be reckoned, a dynamic figure in an immensely popular WARS group of our country with an objective to make a difference. So let us see what she has to tell us.
Good evening, ma'am. Thank you for welcoming me here. And there's a little difference in the fact that I'm working with another corporate, which is Fortis now. Okay. And I'm heading the Fortis at the Vasant Kunj and the Escorts Delhi. Thank you, panel, for inviting me here, and friends, colleagues, and my seniors. Amongst you, I'm a small little fry in the field of ophthalmology, but I want to share a technology which we are all aware of, but unless we explore a technology with its USPs, we can't use it in every situation, which I felt in all the previous videos. If we had that closed chamber technology with us, we could have prevented some of the complications. I'm going to share my slides. I'll go through the slides first and then my video.
Not able to share?
Yeah, I'm going to just do that now. Flags friendly in difficult situations. We all know that despite femtolaser assisted cataract surgery received FDA approval in 2010, the jury is still out regarding its utility, advantages, and disadvantages. Femtolaser is a very fast laser. We all know that, 153 nanometer, and it is nanojoules, the energy which is delivered. I just wanted to brush upon all its USPs to understand that it's a very fast pulse duration, and it uses a photo disruption. Laser creates a plasma that generates a shock wave, and this creates a gas bubble that expands before it collapses, thus creating a cleavage plane. So it really has a very minimal collateral damage. Hence, we can deal with all kinds of grades of cataracts. The femtolaser gives very high precision, predictability. Together with the complex programming, we can monitor, tweak each parameter by understanding the machine more. So I think it's a learning curve, and more we do all kinds of surgeries, we really learn with every patient. It can be linked with a real-time spectral domain anterior segment optical coherence tomography with Schlemflug imaging on a larger screen. A live camera is on, and we actually can create pre-programmed cuts at different levels within the transparent ocular tissue. Of course, as I said, there's a learning curve. And when I every time I also look up the text to understand what a femtolaser is all about. And I feel that it really utilizes a low energy with a pulse rate, with a high repetition rate, and a short pulse width to achieve small overlapping laser spots, resulting in consistent cuts. And no low energy delivery of the energy leaves the cornea transparent, and it is found that the opaque gas bubble layer is not going to hamper the transparency of the cornea. Flax is helpful to safely create a rhexis, shallow anterior chamber in white cataracts, subluxated cataracts. It can create an anterior posterior capsulotomy, mainly in pediatric cataracts, as we discussed in the previous videos as well. It can also make the nucleus remover safer, because the endothelial and epithelial dystrophy cases, we have a lot of apprehension that we may just not have that kind of a clarity, and the steps we do may not be as precise. It makes routine cataract surgery easier in the less experienced hands. And of course, for experienced surgeons, I think we are all aiming for the best precision and perfection. It causes, as I said, the endothelial damage is least, and endophthalmitis is also had lesser incidence as documented. Nuclear fragmentation softening can decrease the intraocular manipulation, as we were seeing in all particular videos as we went across. Effective phaco time, cumulative dissipated energy, potentially decreasing the endothelial and other complications, as well as the vitreous loss in the CMEs. Technology helps to create consistent results with the customized capsulotomy in corneal wounds, pre-fragmentation crystalline lens. And as it identifies the lens density, which I'll just come across as I go through the slides, The technology is very good for trauma cases where there may be an anterior capsule opening, as we saw in Dr. Kamal's case. And in such cases, because of injury, we can have a closed chamber, better precision. Of course, as we know that the docking is very, very precise, the tilt of the patient and the noise created by that is very well taken care of, the very good fitting the interface. And the patients, such patients where there is a little nodding of the head in cases of Parkinson's, or in cases where there is a lot of anxiety, the centration is particularly taken care of by, there is an iris registration by the structure of the iris more than the limbal vessels. So that has more precision, and deeper orbits, high eyebrow may not be good candidates, but of course there is a pre-registration, and the adjustment of the docking happens before we shoot the laser. Centration, of course, is ascertained by the real-time images and evaluated for quality and tilt. The scans can be repeated, and rather before shooting the laser, the machine automatically rescans it. Position of the chosen sets, the cuts are verified as desired in the safe zone. Cuts start with rexes followed by lens fragmentation, softening, clear corneal incision, and astigmatic keratotomy. It particularly has a very strong role in doing the LRIs, because it scans the span, the diameter, the depth, and the kind of the penetration. So we can play with the energy in all the LRIs as well. Cuts larger than 6 mm should be avoided, which I keep telling myself, and a clearance of 1,000 microns, 800 to 1,000 microns from the posterior capsule, and 250 microns from the pupillary margin just avoids the injury. If the patient
go on to your video.
Yeah. Okay. So I just wanted to lay emphasis on the fact that if a smaller pupil is in hand and a flatter anterior chamber also in hand, how I dealt with this particular, I think, okay, I'll go in for my straight away my video.
Yeah.
I'll just close this. And I could actually utilize a whole lot of my take homes. I'll just share my video. I have to just stop share this, and I'll go into my video. Just a sec. Shares.
And should I click from my side?
Yeah, I've done it.
Yeah.
Please reduce the volume. The volume is too high and we can't get you.
So he was a 3 millimeter pupil.
Ma'am, still very high volume. You can remove the volume.
We want to hear you. Yeah.
Okay. So I maximized the pupil. The diameter, you can say, was 3.9 millimeters. We had to do an LRI because he had astigmatism as well. The phaco time, I had to increase the repetition rate because the cataract was grade 3+. He was 80 years old. And so the LRI, perhaps, which I will just come across in the video, also one has to understand that the energy levels and the repetition rate also affects the LRI. So when I started doing the case, I saw the eyeball was very hard. You can see there is a floppy iris. He was an old man on anti-prostates also, which I had stopped, and I'd put him on atropine also, but of no effect. There is already bleeding because of being on the blood thinners. So when I saw that it was very stony hard in a very flat anterior chamber, I was a little perplexed. So I removed the speculum, and I thought that I should give mannitol to this patient. We waited for a little while, which always is very handy, that you should have patience. And I could see that I then started the surgery with a little better intraocular pressure in the patient. I did the hydrodissection, and I didn't use any of the aids because, as I said, he was on blood thinners. So I could get a central bulk of the nucleus. And since it was Also, as I said, that the femto transmits the energy in a hard cataract also. I knew that the debulking of the nucleus has happened. So I started only working on the central 3.6 millimeters, which I got. I removed the hard cataract. And since it was a nuclear cataract, the IA part was very little. You can see the rexus, which is intact, and the lens, which can easily fit into it. So what saved my anxiety was the fact that I was really working in the central 3 mm area to fit in a lens really in the effective lens position with all my little tweaking of the parameters. I just wanted the forum to discuss one thing, that why I had AC flattening before the surgery. I felt the LRI was, it just gave way before I could release, I could really open it. So because I didn't understand why the AC became suddenly so flat.
AC, it didn't look as if the AC was flat. I felt it was a very tensed eyeball. And this could probably have been because you had a small rexus and a hard cataract and a lot of cavitation bubbles which were there behind, and the intralenticular pressure must have been quite high. And over and above, it was a case of a floppy iris. So everything was additive in your case. So I think you managed very well. It is about in giving mannitol and waiting it out and doing it, and how you ensured that you released all the cavitation bubbles as you went to sculpt the lens. The only tip which I would have given at this point is we are able to lessen the rexus to significant levels in the pupil maximized mode. But after completing the case, it is important that we enlarge the rexus, make a nip, tangential nick, and enlarge the rexus, because you wouldn't want to end up with a capsule phimosis in these kind of situation. That would be the only thing which I would wanted to have done extra. I would want Anaga, since she's here, you have anything to add, Anaga?
Yes, ma'am. A lovely case, Dr. Aarti. And even I have found in 2-3 patients when I had a smaller size pupil, where I have gone up to 4.1, 4.2. 3.9 is slightly on the lower side. But what I've done is I've gone on to in the main cataract, I've put in a B-hex ring and enlarged the pupil. I'll enlarge the CCC like what ma'am said, and then went on to do the surgery, because especially like we saw in your case, the pupil was really coming down, and with a very tense eyeball like this, you are lucky that you didn't have an event or a complication. Otherwise, it was a very high risk case. So, and one more thing I wanted to ask you, was it under a block or was it a topical?
It was under a block.
Yeah, so when you've given your block, would
after the femto.
Yes, right. So at that time, was the eyeball soft after the block?
When I took up this case, there wasn't any indications for the pressure to be high, except for the fact that
Yes, so this is
a hard cataract.
right.
And because maybe that is why I was just wondering that suddenly when the pressure rose, and I saw a flatter anterior chamber to deal with. So perhaps the aids, as I said, the pupillary expanders and all, I avoided being a very, very old patient on and blood thinners for a very long time. So any intervention
That doesn't
before
really
applying
matter
laser,
actually. Blood thinners may not really make any difference.
no,
And stopping the prostate, this
was
thing
on
also may not really change the
stronger blood
how
thin.
the iris behaves in if it's a floppy iris. But putting in a BX or a iris retractor, whichever, especially a BX, could have probably reduced the stress during surgery, because if you had a complication, then you would not really know where the rent would be, or how each step would have been more and more difficult, especially as it was a very hard cataract.
Dr. Ramurthy, Dr. Kamal, yes, Dr. Kamal.
I would have dealt with it a little differently. I mean, an initial step in the sense that, with the LensX machine, you are able to exactly position your rexus depending upon the pupil diameter that you have. Even with the catalyst which you used, the default setting is that, when you go on to pupil maximized mode, it allows 500 microns from the rim of the pupil, which is not really necessary. You can manually override that And you make if you have 500 microns left all around, when you have a 5 millimeter or a 4.9 millimeter pupil, the rexis size that you get is only 3.9, which is what you got. But in this case, you can ask the technicians to help you. You can manually override that so that you can enlarge the pupil, the rexis. But with a 5 millimeter pupil, you can get as much as a 4.8 millimeter rexis. And that's the first step I would do. And if I'm getting something like a less than a 4.5 millimeter rexis or a 4.4 millimeter rexis, I always check. Then I would not go ahead and create the rexis with a laser. I would actually go ahead and do it manually, because I know that, as was mentioned with pupil expander and other devices, especially in a hard cataract situation, you can end up with a more adequate rexis, allowing you to do the surgery in a better manner. As regards the TENS eyeball, one of the reasons could be that it was a fairly hard cataract. I think you used fairly high energy settings. The amount of cavitation bubbles that was formed fairly higher, because of which the anterior chamber became a little shallow. The moment, I would have gone ahead, and in this case, what I would have done is to gone through the side port, depress the central nucleus so as to allow the cavitation bubbles to come out. That itself, and injected some amount of viscoelastic. I do not think that the laser arcuate keratotomies, I found that it was a single arcuate keratotomy. Most often I use a pad keratotomies. That's what works adequately. And in these cases, hardly ever go through and through, because they're at 80% depth. I don't think that was the reason for the AC being shallow. It was a difficult case, well managed.
Yes. Yes, Dr. Kamal?
I agree with Dr. Ramurthy. You can do a manual override. We have LENSAR machines, and there too, we have a default setting, which is 750 microns if you override. My cutoff is anything less than 3.9 or 4 millimeters. If I'm getting, when I dock, the machine gives me what would be the size of rexis. I go on a manual override. If it still gives me a small rexis, I would probably put my ego aside and go for manual, as Dr. Ramurthy said. But if the patient is too hard pressed, then my choice is doing a B-hex expander. I use a side port, 1.5 millimeter side ports, which don't leak even when you dock, and especially with my machine, the IOP doesn't go up. So I use a side port to use the B-hex expander, and then I do it. But I think we let the message go loud and clear that the pressure to do a femto should be kept outside the operation theater. What is best for the patient should flow in. And this is one thing I think as we are moving along, we all should realize that in the end, if the patient is happy and he knows you've taken a decision in his favor, and the language which we use in the post-op is that, the doctor had a choice of going ahead with that, and that could mean more money to the organization, but we deferred that, we refunded your money, but because doing that probably was safer in your case, and most of the patients understand that.
In fact, if the patient has a semi-dilated pupil, even in the OPD, when we counsel them, we make it a point to tell them that we will decide on table whether we will go ahead with the flax or not.
Yes.
The
Very
choice
well
of
said.
doing laser was, of course, mine, and I assumed that the energy levels will make the bulk of the nucleus softened. So I chose to go ahead with flax.
Dr. Aarti, high amount of energy also makes the pupil go smaller. And as Dr. Ramurthy said, if you actually go for a capsule rexis very near the rim of the pupil, then also after the surgery, the pupil will go small on you, because there's so much of energy dissipation near the rim of the rexis.
Prostaglandin release.
Good discussions.